The Initial Management of Chronic Pelvic Pain. Green Top Guideline number 41, May 2012. Background and Introduction. Chronic pelvic pain can be defined as intermittent or constant pain in the lower abdomen or pelvis of a woman of at least 6 months in duration, not occurring exclusively with menstruation or intercourse, and not associated with pregnancy. It is a symptom, not a diagnosis. Chronic pelvic pain presents in primary care as frequently as migraine or low back pain and may significantly impact on a woman's ability to function. Living with any chronic pain carries a heavy economic and social burden. Aiming for accurate diagnosis and effective management from the first presentation may help to reduce the disruption of the woman's life and may avoid an endless succession of referrals, investigations, and operations. What are the possible etiological factors in the genesis of chronic pelvic pain? There is frequently more than one component to chronic pelvic pain. Assessment should aim to identify contributory factors rather than assign causality to a single pathology. At the initial assessment, it may not be possible to identify confidently the cause of the pain. Pain is, by definition, a sensory and emotional experience associated with actual or potential tissue damage or described in those terms. The experience of pain will inevitably be affected by physical, psychological, and social factors. The woman is often aware of these influences, but may choose not to discuss them, fearing that her pain will be dismissed as psychological or that non-gynecological symptoms will be considered irrelevant. Careful scrutiny of the woman's history and physical findings will frequently reveal factors that may be contributing to the pain and can therefore be at least partially treated. Given the incomplete understanding of the genesis of pelvic pain, it may be necessary to keep an open mind about the cause and consider unusual diagnoses such as hernias or retroperitoneal tumors. It is important not to leave the woman with the feeling that nothing more can be done to help her. Central and peripheral nervous system. Nerve damage following surgery, trauma, inflammation, fibrosis, or infection may play a part in this process. Pain as a result of changes in the nerve itself is termed neuropathic pain and is characteristically but not exclusively burning, aching, or shooting in nature. Endometriosis and Adenomyosis. Pelvic pain, which varies markedly over the menstrual cycle, is likely to be attributable to a hormonally driven condition such as endometriosis. The cardinal symptoms of dysmenorrhea, dyspareunia, and chronic pelvic pain are said to be characteristic of endometriosis or adenomyosis. The combination of clinical examination and transvaginal ultrasound accurately identifies ovarian endometriosis but not peritoneal disease. Symptoms alone are a pure predictor of finding endometriosis at surgery, but a causal association between the disease and the severe dysmenorrhea probably exists. It is important that dysmenorrhea in adolescents is not overlooked, as adenomyosis and endometriosis certainly occurs in the group. The existence of pelvic venous congestion as a cause of chronic pelvic pain remains controversial. A recent systematic review of diagnosis and management of this condition found no valid diagnostic tests, although ovarian suppression was effective in treating pelvic pain symptoms. In women suspected of having this condition, Both progestins and gonadotropin-releasing hormone agonists were shown in randomized controlled trials to effectively decrease pain during therapy, with gonadotropin-releasing hormone agonists showing higher efficacy. Strikingly, cyclical pain is likely to be gynecological in nature. Adhesions. There is no evidence to support the division of fine adhesions in women with chronic pelvic pain. Division of dense vascular adhesions should be considered as this is associated with pain relief. Adhesions may be a cause of pain, particularly on organ distension or stretching. Dense vascular adhesions may cause chronic pelvic pain. However, adhesions may be asymptomatic. Adhesions may be caused by endometriosis, previous surgery, or previous infection. Two distinct forms of adhesive disease are recognized. One, residual ovary syndrome, in which a small amount of ovarian tissue inadvertently left behind following oophorectomy, which may become buried in adhesions, and second, trapped ovary syndrome, in which a retained ovary becomes buried in dense adhesions post-hysterectomy. Removal of all ovarian tissue or suppression using a gonadotropin-releasing hormone analog may relieve pain. Irritable bowel syndrome and interstitial cystitis. Symptoms suggestive of irritable bowel syndrome or interstitial cystitis are often present in women with chronic pelvic pain. These conditions may be a primary cause of chronic pelvic pain, a component of chronic pelvic pain, or a secondary effect caused by efferent neurological dysfunction in the presence of chronic pain. Musculoskeletal. Musculoskeletal pain may be a primary source of pelvic pain or an additional component resulting from postural changes. Pain may arise from the joints in the pelvis or from damage to the muscles in the abdominal wall or pelvic floor. Pelvic organ prolapse may also be a source of pain. Spasm of the muscles of the pelvic floor is proposed as a cause of pelvic pain, which can be reduced by botulinum toxin injections. Nerve entrapment. Nerve entrapment in scar tissue, fascia, or a narrow foramen may result in pain and dysfunction in the distribution of that nerve. The incidence of nerve entrapment, defined as highly localized, sharp, stabbing, or arching pain, exacerbated by particular movements, and persisting beyond 5 weeks, or occurring after a pain-free interval, after one Phanencedale incision is 3.7%. Psychological and social issues. Inquiry should be made regarding psychological and social issues which commonly occur in association with chronic pelvic pain. Addressing these issues may be important in resolving symptoms. Depression and sleep disorders are common in women with chronic pain. This may be a consequence rather than a cause of their pain, but a specific treatment may improve the woman's ability to function. Similarly, women with chronic pelvic pain tend to suppress their unwanted thoughts and feelings, either as a cause or consequence of their pain. The relationship between chronic pelvic pain and sexual or physical abuse is complex. Those who experience chronic pelvic pain specifically are more likely to report sexual abuse than women with another chronic pain complaint. It may be that, for some individuals, child sexual abuse may initiate a cascade of events or reactions which make an individual more vulnerable to the development of chronic pelvic pain as an adult. Women who continue to be abused are particularly at risk. What should underline the initial assessment of chronic pelvic pain? Adequate time should be allowed for the initial assessment of women with chronic pelvic pain. They need to feel that they have been able to tell their story and that they have been listened to and believed. Many women present because they want an explanation for their pain. Often, they already have a theory or a concern about the origin of the pain. These ideas should ideally be discussed in the initial consultation. Consultations which elicit the patient's ideas will result in a better doctor-patient relationship and improve concordance with investigation and treatment. Women with chronic pelvic pain want their experience to be heard and validated, and they want to receive personal care to help them understand and manage their pain. Particularly if they have had negative experiences previously, women may need to be encouraged to talk about their symptoms and ideas, allowing them to influence and shape the doctor-patient relationship as a partnership. The multifactorial nature of chronic pelvic pain should be discussed and explored from the start. The aim should be to develop a partnership between the clinician and the woman to plan a management program. An integrated approach with equal attention devoted to possible organic, psychological, dietary, and environmental causes of pain causes greater pain relief. History. The initial history should include questions about the pattern of the pain and its association with other problems such as psychological, bladder and bowel symptoms, and the effect of movement and posture on the pain. Symptoms alone may be used to diagnose irritable bowel syndrome positively in this group. On taking the woman's history, special note should be taken on any red flag symptoms, which may need further investigation and referral to a specialist. If the situation allows, it may be helpful to ask directly about past or present sexual assault, particularly intimate partner violence. The doctor must be prepared to listen and accept these experiences as stated and know where to access specialist support. Completing a daily pain diary for 2 to 3 menstrual cycles may help the woman and the doctor identify provoking factors or temporal associations. The information may be useful in understanding the cause of the pain. It may be helpful to establish the woman's level of function at the start of treatment, for example, time of work, avoiding activities, both to monitor progress and to emphasize the value of functional goals. Asking which drugs have been used previously and whether or not they helped may be helpful both to aid diagnosis and to plan effective management. A number of validated symptom-based tools are also available for the detection of psychological comorbidity. However, simply inquiring generally about things at home and symptoms such as sleep or appetite disturbance and tearfulness may be enough. If the history suggests to the woman and doctor that there is a specific non-gynecological component to the pain, referral to the relevant healthcare professional such as gastroenterologist, urologist, genitourinary medicine physician, physiotherapist, psychologist, or psychosexual counselor should be considered, usually via the general practitioner. Examination. The examination is most usefully undertaken when there is time to explore the woman's fears and anxieties. The examiner should be prepared for new information to be revealed at this point. The assessment should include abdominal and pelvic examination looking particularly for focal tenderness, enlargement, distortion or tethering, or prolapse. Highly localized trigger points may be identified in the abdominal wall and/or pelvic floor. The sacroiliac joints or the symphysis pubis may also be tender, suggestive of a musculoskeletal origin to the pain.